Hi, and welcome to Complex Coronary Cases from the Leeds General Infirmary. This is a case of a complex right coronary artery chronic tertiary occlusion. So this is a 67-year-old man who had previous coronary artery bypass surgery and presented with recurrence of angina and was found to have occluded both the grafts of the circumflex and RCA. The circumflex was treated with an antegrade dissection re-entry technique, but despite this stage he had ongoing symptoms, so was planned for stage PCI to the right coronary artery chronic occlusion using a retrograde technique. The setup was a 7 French biradial access, as is our standard. This was a 7 French flow to left 3-5 guide to the left coronary and a 7 French AO1 guide catheter to the right coronary artery. You can see a long right coronary occlusion from the proximal vessel with a clear cap, although the vessel course is ambiguous. There is a branch at the proximal cap. There are interventional collaterals, as you will see here, from the first septal with several promising connections to the distal PDA. However, the PDA PLV distal bifurcation appears to be disconnected. So the plan was for a retrograde approach using the septal collaterals to gain access to the PDA, open the occlusion, and then clarify the distal bifurcation and try to open this with an antegrade technique. So we started with a Mamba Flex 150 centimeter microcatheter from Boston Scientific, and this was a C-on wire easily crossing the septal to the distal PDA. We take a contrast injection here just to confirm that we are in the PDA before advancing any equipment. And we will check in a different view now. And so from here we can see that yes, we are in the PDA. There is slight tortuous course in the PDA at the graft anastomosis site, so the wire is now bypassing the graft anastomosis site, working up its way up the PDA, and there does appear to be a likely second CTO at the bifurcation with the PLV. So here we spent some time wondering whether we should stick to the plan to open the PDA or go for the PLV. And our feeling was that opening the PDA to the RCA would then allow us to open the PLV with an antegrade technique. So here is the crossing of the Mamba Flex 150 centimeter catheter. This crosses very nicely from the septal to the PDA. And at the distal bifurcation, we then took a Pilot 200 wire to puncture the cap and to form a knuckle. So we now go on to advance the knuckle, followed by the microcatheter. Withdraw the wire back into the microcatheter and push again. And we can see here that the size of the knuckle is large, giving us an indication of the size of the vessel, which is at least 4 millimeter vessel by the size of this knuckle. So slowly but surely we made good progress up the right coronary artery. So this is to the Pilot 200. Doing a good job. It's very good knuckling wire. So we're now approaching the proximal RCA, and here there does appear to be some tortuosity in the vessel, and the microcatheter appears to be deviating to one side. It's still unclear whether we have deviated into a branch. In this view, it appears possibly we have gone into a branch. The best way of clarifying this is to knuckle further. So here we take a Fielder XT knuckle. Having withdrawn the microcatheter slightly, the XTA now appears to be taking a better alignment. Although there is certainly tortuosity in the RCA. So you can imagine trying to wire this retrograde with stiff wires would have proved very difficult and potentially dangerous, with likely exit of guide wires. But with a knuckle wire, we are able to stay within the vessel architecture at all times and clarify the course of the artery. So here the Mamba Flex catheter was easily advanced following the guide wire and is pushed on further all the way to the proximal cap. We're very close now. And so we just take it on a little bit further. There you go. So now we are at the proximal cap. So this gives us a very nice target for antegrade puncture, and will hopefully allow us to stay within vessel architecture. So we then move to antegrade preparation. So the initial plan, as we had so clearly defined the cap, was to directly puncture the cap with a Confienza wire, as we felt that we would easily be able to hopefully stay within architecture given the retrograde landmark. So here is a Confienza wire scratching the top of the proximal cap and appears to puncture accurately and appears to be in sync with the retrograde equipment. So here we're having some thought about whether we think we are in the right place. And having concluded that we probably are, we advance the catheter through the cap with a plan to see if the wire will continue towards the retrograde equipment. We checked in the RA view and it appears to be good, and the Confienza wire was advanced a little bit further and does appear to be in alignment. However, back in the LAO view, the Confienza wire is a reasonable distance away from the retrograde wire. But potentially does appear to be dancing. So we chose to advance the Mamba Flex through the cap and de-escalated to a Pilot 200 wire. So here comes the Pilot 200 wire, and quite quickly you can see that actually it's not really knuckling and is behaving in an odd manner, and does not appear to be within vessel architecture, particularly at the distal part. So we then make a decision to change tact and to perform what's known as a base technique, which is balloon-assisted subintimal entry. We put a wire down the branch at the proximal cap. We inflated a 3 mm balloon in the proximal RCA, inducing dissection, and then took a Pilot 200 polymer jacketed wire and found the dissection plane, and with the balloon inflated, forced this into the dissection plane and formed a knuckle, and that took a much more welcome approach, and this looks much better now, and we feel we're in a much happier place. A 135 Mamba Flex was then advanced into the same space, and the knuckle was taken on, and this is a much better alignment, and now we are happy that both antegrade and retrograde equipment are in the correct space. We again check in REO, and this all looks good. So here I'm advancing the Antegrade Mamba Flex, and then we drew the Pilot on the wire and took a Fielder XT, and this shows clear overlap with the retrograde equipment. So then it was a simple case of guide extension assisted reverse cart using a 7 French Guidezilla balloon was inflated on the antegrade equipment, and as you can see here, the guide extension was easily wired. This was then trapped with a balloon, and the retrograde Mamba Flex was advanced into the antegrade guide catheter, and an RG3 wire was externalized. Other approaches, once you have the retrograde microcatheter in the antegrade guide, are to perform tip-in maneuvers. And this could be particularly useful if it is not possible to externalize an RG3 due to tortuosity, which can occur particularly if via a very tortuous retrograde channel. So then on the RG3 wire, we perform predilation of the occlusion segment, having withdrawn the microcatheter back to the PDA. When you are withdrawing microcatheters, it is important to have the retrograde guide catheter way out of the left corneosteum, as this can be sucked in. So successful balloon expansion. So next we took a dual lumen catheter, this time the twin pass, and using this we were able to wire the PLV with a Pilot 200 wire again. It's confirmed with retrograde contrast injection. And the PLV is then wired successfully. We then dilated the PLV branch also, and subsequently performed intravascular imaging to determine the need for any further dilations and how to treat the bifurcation. There's quite a lot of tissue playing between the PDA and PLV, with likely dissection from the main vessel back into the PLV. So to ensure that both vessels were patent, we elected to perform a mini crush bifurcation stenting procedure for the distal bifurcation, with firstly a stent from the PLV back into the main RCA, and then a stent from the PDA to the RCA, having withdrawn the equipment from the PLV. This is then the PDA stent being deployed, crushing the stent from PLV. So we then placed a further 2 long drug-eluting stents from the distal right to the ostium of the right coronary artery, using IVUS to then optimize. This was a 4mm by 38 stent. As a proximal stent placed, and then we rewired the PLV and performed kissing inflations at the distal bifurcation. Sequential high pressure inflations followed by kissing inflations at nominal with 2.75mm balloons in each limb. And we performed final post-dilations of the RCA. And here is the final result. Very good angiographic result with flow into both the PDA and PLV branch. Thank you for joining us for this case presentation.